Well, hi, everyone. So thank you so much for joining us. This is a webinar entry and part of our series that we've been doing on confronting the drug war. This webinar series is really intended to interrogate a lot of the underlying logics of the war on drugs and really think through how we can move beyond them to have drug policy that's more equitable, that's grounded in justice, and focused on addressing the harms that we experience under criminalization and the broader prohibition of drugs. The webinar series is co-sponsored by the Yale Program in Addiction Medicine, UCLA's Center for Social Medicine, the drugs program at the L'École en études sciences sociales, which I'll butcher because my French is horrible, the Drug Policy Alliance, and the National Survivors Union. We're pleased to partner with them to bring you what has been a really fascinating series so far that's explored everything from safe supply to drug consumption rooms, to narco-feminism, all of which are available as recordings on our YouTube channel. And I would encourage people to check those out if they're interested in seeing what we've covered to date. This particular webinar will go up on the YouTube channel once it's been done. And I would encourage you to share it with folks who you think might benefit from what I hope and anticipate is going to be a really wonderful discussion today about the dynamics of drug markets, penalties for folks who sell drugs, and kind of what's happening now in the moment of rapid transformation of the illicit drug supply. So I'm Ryan McNeil. I'll be moderating today. I'm an associate professor in internal medicine, public health, and anthropology at Yale University, and director of harm reduction research with the Yale Program in Addiction Medicine. And I am really excited to be bringing together our guests today, who I think we can learn tremendously from. I'll introduce them by name just to flag them for you, and then they'll introduce themselves. So we're pleased to be joined by Kenna Hayashi from Simon Fraser University in British Columbia, Canada, and the British Columbia Center on Substance Use. Louise Vincent with the National Survivors Union, and Saba Rouhani at New York University. And I'll just kick it to them to briefly introduce themselves, starting with Kenna.
Thank you very much, Ryan. And thank you for inviting me to this fantastic webinar today. And as Ryan just introduced, my name is Kenna Hayashi. I'm joining today from the unceded traditional territories of the Coast Salish peoples, including Musqueam, Squamish, Tsleil-Waututh nations, which is now called Vancouver in Canada. And I'm an associate professor at SFU Simon Fraser University. I'm an epidemiologist, and then also I employ community-based research approaches to my research. I currently lead a prospective cohort study of people who inject drugs in Vancouver, mostly in the downtown east side neighborhood, which is called the Vancouver Injection Drug Users Study that's been running for more than 27 years now. And I'm really excited about this panel discussion today. Thank you.
Great, thank you. Now, Louise. Oh, Louise, you're muted.
Sorry. My name's Louise Vincent, and I'm with the National Survivors Union, and I'm with North Carolina Survivors Union. I work as a person who uses drugs. I have a master's degree in public health. This is my work, my heart, my life, and I'm really grateful to be here today. I'm a little under the weather from traveling to the DPA conference, but never too tired for this. So thanks for having me.
Great, thank you, Louise. And I feel like that's been everybody traveling back from conferences lately. Everyone ends up sick. Saba, and I hope you're not sick traveling back from Reform too.
Somehow I made it out unscathed. I got my COVID vaccine like 13 days before, so I think I was really riding high on antibodies during the conference.
I was bad. I should have done like you.
Well, I hope you feel better, and thanks for being with us when you're sick. I'm really excited to be here. My name is Saba Rouhani. I am an assistant professor of epidemiology at the NYU School of Global Public Health. And I'm also a core faculty member of a new center that we have here called the Center for Anti-Racism, Social Justice, and Public Health. And my research really is at the intersection of the contemporary overdose crisis but also the contemporary crisis of policing and police violence and over-policing, and the public health risks that poses, and sort of the ways that these two things are amplifying each other's harms. And I'm interested, especially in how some of the changing drug laws, both the more progressive ones and the more punitive ones, are impacting racial justice work, as well as the health and dignity and sort of liberty of people who use drugs.
Great, thank you. Now, to get us started, as folks will know, we're focused today on drug market changes and specifically some of the penalties that are being brought in for folks who sell. Now, we all know that these are being implemented amidst incredible changes to the drug supply, how we approach drugs, and yet this is all kind of happening alongside very entrenched views and framings of drug use. So as an example, we have seen decades of problematic media coverage of folks who use drugs, and also very specifically folks who sell drugs, using incendiary language, defamatory images, framing people as predators, and deeply rooted in incredibly racist views of who sells drugs, who uses drugs, and what the attending risks are. And as mentioned, this has also been happening amidst incredible changes to the drug supply. So what have I'd put to all of you, maybe not to put you on the spot, but we'll go a little bit in reverse order this time, starting with Saba. What have these framings meant of drug use as the drug supply has changed and we've seen rising overdose deaths? And alongside that, how have these framings been mobilized in ways that reflect and reinforce deeply rooted, direct and structural racism?
Yeah, I mean, I think that the demonization of people who sell drugs is not new, and nor is the sort of racialized criminalization of selling drugs. But what I feel that the stakes are getting higher, right? So, whereas before it was like this reefer madness narrative of people luring nice white kids into a life of like sex and drugs and rock and roll and maybe dropping out of school or being lazy. Now the narrative is that these are like people who are committing premeditated murder, who are luring nice white kids to their death. And obviously, and this is all happening, as you said, amid a really, really volatile drug market. And we know that sort of cracking down more and more on supply side crackdowns only add to the volatility of that market. So that's kind of how I see it, is that the narrative unfortunately has only gotten more intense, but the stakes have also gotten a lot higher. And particularly in an environment where in many settings, charges for possession or treatment of people who use drugs is softening to some extent. And so this disparity between the sellers and the people who use drugs is widening and widening.
Yeah, thank you. Louise, I'm wondering if you could tell us a little bit more, for folks who use drugs and drug user activists, what are these framings meaning right now? And what are you seeing in the work that you're doing? Because I know you do a ton of work to combat these. Oh, and you're muted.
If I don't mute, then it'll be a problem. This is some of the most damaging these narratives are some of the most damaging things that are happening. As COVID came, the drug supply completely changed and became absolutely devastating. And it's been devastating to people throughout. And as it's not supply and demand. We don't want something and then get it. It is, you get what's on the street, right? And, people end up asking for the things that are some of the most damaging, which is part of the problem, right? People said forever, oh, people don't want fentanyl, and people didn't want fentanyl until they needed fentanyl, right? And so people don't want these drugs until they need them, and then they express that they want them. And so it's not the kind of damning evil thing that you might think it is. Certainly there's young people in need of money, and if there's no supply other than what's available, that's what they get. And there's no way to, most places do not have FTIR machines, do not have drug testing machines, drug sellers and users are not completely sure they want to use them. I mean, these are huge trust issues. As the drug supply becomes more unstable, so does the drug market. And when the drug market is unstable, trust is low. And when trust is low, we have young people, high prison terms, drug-induced homicide laws, all of these things happening. People don't trust one another. And then we have people overdosing and dying on their first use and second, and so people don't use the same as they used to. It's not something you do socially. In fact, you might not want to, somebody that's at high risk for overdose, it used to be you would definitely want them to use, with you or around you. Now somebody that's at high risk for overdose might be ostracized because, they overdosed the last 3 times this happened. I don't want to deal with that. That brings the police, that brings, so all of this instability, you don't have instability in one place and not instability in another. And so we have these huge trust and, there's just no trust. And so when you have good health hubs, syringe exchanges, drug user centers, it's a blessing. So like in Greensboro, North Carolina, we do have huge trust because we've had a center there for forever, for a lot of years. And so we have developed trust over the years, but we still see a decrease. So that's just a small sort of picture of all of the instability. And even with a lot of trust, we still struggle. And, it's tough.
Yeah, no, thank you, Louise. I think certainly, we are in a period of volatility, mistrust, and like this deep effort to try to respond as things are changing. Ken, I'm wondering if maybe for people joining, just so we're kind of sure we're all working from the same space, if you could really just take a moment and just characterize what's happened with the drug supply really over the last 10 years as an example, and kind of what is out there right now.
Yeah, like Sava just mentioned at the beginning, so demonization of drug sellers has been there always, but then I think it's really the narrative has got like worse and then really aggressive since really the drug supply has changed. Like 10 years ago, like around 2013, at least in Vancouver, we have seen more penetration of the recently manufactured fentanyl into the drug supply, so that people are getting sort of like down, right? Like those are like straight opioids. But it used to be having a lot of heroin in it, but then now like the fentanyl penetrated in the supply, so that without knowing, those downs started to have more concentration of fentanyl, so that people started to overdose more. And then a few, I would say maybe 5, 6 years ago, and then now like benzodiazepines being penetrating in the drug supply. So people are calling it the benzodopes now. And it's just a little bit of xylazine, which is a slightly different characteristic from other setting in the north east coast, but a little bit of xylazine in there. So that the problem with the drug supply is over the past 10 years is that you really don't know what you're actually getting from the supply. And you can't blame, especially the low tier level, like drug sellers for that, because those people also don't know what's in the drugs they're selling. And as many of you know, the drug market operates like in a very hierarchical model, so that a lot of people, especially where thinking as drug sellers are people on the street, and usually those are the people who are also using drugs, and the very most vulnerable, I would say, a subpopulation of people who use drugs, who had to like engage in a drug dealing as for survival. And those people are really, as far as I know, like I don't have specific data to point to, but a lot of you are trying to make sure the drugs they're selling, even though they don't know, they're not told by other higher ups, but try to make sure whether those drugs are containing fentanyl or not by doing drug checking for their customers or their peers. So that, but then those are not always adequate. Like, there's not that much adequate services out there. So that I think it's really unfair to blame those low level like drug setters for selling really dangerous drugs to people.
Yeah, no, Hannah, thank you. And I appreciate that. This is something my team has done a little bit of work on in the past, where we had been doing interviews with folks who were selling drugs about how they were interacting with drug checking out. It might be of interest to folks. So I posted, it should be open access in the chat. But what we effectively found is, as Ken, I think, really smartly characterized, so many of the folks who are selling drugs, they are folks who use drugs. They're selling to people within their social networks, people they care about as part of their community. And this view of them as nefarious, predatory actors out there preying on what I think Saba hit this really nicely, is commonly characterized as like your kind of drug naive white person or child who may use, really betrays who it is that sells drugs and the deep care that they often have for the communities that they're part of. It's been touched on a little bit, but certainly we know one of the responses that have been brought in as we've seen, especially the increased risk associated with the supply, has been drug-induced homicide laws. And they've been increasingly utilized to prosecute people who share, trade, or sell drugs after a fatal overdose. And, unsurprisingly, there's significant racial disparities in who's charged. To put this maybe to you, Louise and Saba, if you could maybe explain to us a little bit about how these drugs have been operationalized and what that has meant for people who sell, but also people who use drugs, because these bring with them especially incredible concerns about how they might interact with, for example, Good Samaritan laws.
Saba, do you want to go first or do you want me to go?
After you, always.
All right. I always say, like, drug culture is one that is a kindness to give people drugs, right? Like oh my goodness, I'm so sorry. It is a kindness to give people drugs. It's one of those things that we do. You would be seen as somebody, there would be something wrong with you if you use drugs and you refuse to share drugs and had no reason for that. We don't, drug sharing. I mean, they just changed the law in North Carolina, I believe, that it's now giving drugs that will get you in trouble for a drug-induced homicide law. And I don't believe the distinction between giving and selling was even discussed in any way it shouldn't be any of them. But giving, you become sick, and if you need drugs and someone has them and doesn't give them to you, that's a problem. People that sell drugs are the same people that use drugs, and especially on the lower ends. The low-hanging fruit. We are all of the same. People have different ways of accessing money, and a lot of it has to do with what kind of job you can get. And I'm afraid once you're a felon, you're not eligible for many jobs. And if you're a person who uses drugs, maybe you don't operate in a 9-to-5 lifestyle. I have never been very good at operating in a 9-to-5 environment with very strict sort of rules around time. It's just not been, and I see a lot of people like that, especially as we have more of a 24-hour world. But people that sell drugs, I think the way we have built this out, and these drug-induced homicide laws really just make things worse. You can't do anything with a Good Samaritan law. There's not even, I'm not going to say there's not any point, but Good Samaritan laws are not as effective. Okay, so you're not going to be arrested, maybe, but you could still be charged with murder. That kind of takes away this idea, the Good Samaritan idea, that you're going to be focused on the person who's dying, not on yourself and your you know, and you're going to prison for the rest of your life. And I need to tell you, I have been in the situation where somebody needed medical attention, and the police came, and you're being interrogated, and it's terrifying. It's terrifying to love someone that is on the, you know, is dying, and you're being interrogated over here as if you're some sort of murderer. These are not situations that are okay. None of the situations are okay, but it all makes the way people use every single thing we do to tell people to be safe is interrupted by drug-induced homicide laws. Every single thing. Know your dealer. Know the people that you're buying from. Use with people. All of these things are interrupted by the way we shape drug users and drug sellers. And the idea that people want people to die is ridiculous. I don't have any research to show it. I just have, you know, I just have what we see day to day at our office. But I live in a city that doesn't have highly organized crime. So there's not anybody organizing to make sure that things are okay. I think in places where there's more organized crime, there's probably less of the insanity, because nobody knows what anything is in these more rural environments, in these environments that are, you know, I can become a drug seller if I want to. So, you know, I think it's all really complicated, and you have to have cultural competency. You know, we talk about cultural competency in other areas, but we don't talk about cultural competency with drug users and drug sellers. And what happens is we have people making decisions about drug users and people who sell drugs that don't understand how our world is and what our world looks like. And that is a huge problem, because then they just make rules that make sense to what they see on TV and what they see, you know, or I don't know. I don't think there's anything I've ever seen that really captures a reality of what a drug user's life is, or at least a functional person who's using drugs day to day. I mean, drug use is sometimes the most normal part of their life and the most boring. So I just want to put out there that, like, we need to develop some cultural competency around substance use, drug selling, what that even is, you know, and understand that when they slip these words into, now we're going to arrest you if you give someone drugs instead of sell someone drugs, how devastating that's going to be. Yeah, I don't know if I answered your question at all, Ryan. I'm sorry.
No, that's great. And I mean, I think you really surfaced some things that are important for us to consider more broadly. And that's, I mean, certainly there's huge barriers to entering different forms of work for people.
Yeah.
And drug selling is often one of the lower threshold, more accessible things that people within drug markets who are effectively barred from doing so many other things can access. And then
Well,
second,
and
I think you
can I just say real quick, and that also applies to education.
Mhm.
So it's not just, I mean, it really is careers. When I say that, it's not just, you know, going to get a job at the gas station. It's, can you have high hopes to have a career? And that's a real problem. So I didn't mean to interrupt you, but I really wanted to underscore that point, because, you know, going back to school, you have to fill out huge forms if you're a felon, and you better know somebody too.
Yeah, no, I think that's fantastic. And then obviously certainly dovetails as well with, you know, random and routine drug testing for a lot of professions that really don't need it. And I think one of the other important things that you've surfaced that I just want to reinforce for people is, you know, because there's a giant anthropological literature, for example, around how sharing drugs is an act of care within communities and mutual support for people, especially as they navigate poverty, the drug supply, and everything else. And I really appreciate you bringing that up. Saba, I'm wondering if you could talk a little bit more about some of the specifics of kind of what this has looked like in terms of how we've actually gone about drug-induced homicide laws and some of the very specific discontinuities with, for example, Good Samaritan laws.
Yeah, absolutely. Thank you. So I mean, so one thing that I actually learned more recently is that I think we are at 23 states and counting that have specific drug-induced homicide laws that have been introduced, but basically anywhere you can charge someone with a drug-induced homicide because there's just existing precedent, even if it's not a new specific statute. So this is something that people are at risk of across the country. And essentially it is, Louise, you were right, it is for selling or sharing your drugs. If those drugs result or are implicated in an overdose death, you can be charged with anything from a delivery resulting in a death or first-degree murder, like anything in that range. And excuse me, and unsurprisingly, these are deployed most frequently in places where there are huge racial disparities and the overdose deaths are really, really soaring. So I think Ohio, for example, which has been an epicenter of overdose death, is the state, upon my last reading, that has used these the most often. And Leo Boletsky did a study where he looked at all media mentions of people who were charged with drug-induced homicide laws, and absolutely what you said, Ryan, is playing out. There's like huge overrepresentation of racial minorities among the people who are being charged, and also half of those that were charged, according to these media mentions, were friends and family or partners of people. So again, this isn't, I mean, not even that I would agree with that, but this isn't like an effective strategy to deploy some kingpin, or it's to entrap some kingpin and like make them pay a price. This is people who are sharing drugs within their community. And I think it absolutely disincentivizes, as you said, Louise, like just even using with other people, even before you get to the stage of calling 911, just this very, very, very fundamental principle of safety and care is somehow now at odds with like protecting yourself in an era of drug-induced homicide laws, which is dangerous and also just like devastating on a human level. And then, unsurprisingly, in qualitative studies, people have been telling us for a long time, and we have some quantitative data to show this now as well, but it compromises the effectiveness of Good Samaritan laws. So it's like this bizarre, I mean, I think sometimes people just think of people who use drugs as some other alien, like any of us can put ourselves in a position where if you had a bizarre decision tree in a moment where somebody that you love is like at threat of dying, these two laws would be at direct odds with each other, right? But for some reason, like that logic isn't always used when we're talking about people who use drugs. So if somebody has to think, okay, in this moment, and Good Samaritan laws vary hugely as well by context. So in this moment, the Good Samaritan law in my state protects me against charge, but not arrest, or maybe protects me against arrest, but then there's a drug-induced homicide statute in my state. And you're thinking about all of this at a time when like every second counts and you're in a deeply traumatic situation and somebody that you love is in danger. And then, as you said, Louise, I mean, then you're treated as, even if you're protected against arrest or charge, if you're then on the line for murder, like this essentially undercuts the entire point of Good Samaritan laws. And that's something I think we can all understand logically, but it also does bear out in the data. So we did a study in Maryland where we found that 5 years after the passage of a pretty comprehensive Good Samaritan law in Maryland, only half of the people that we spoke to in our study had heard of the law and were clear on like what the Good Samaritan law protected them against, but 87% of people were aware of drug-induced homicide laws, were afraid of them. You know, this is like a real threat that is circulating in the social networks of people, understandably, again, as it would, like, as it does with any of us. And hearing of the drug-induced homicide laws increased the chances that people were concerned about calling 911 in an overdose. And that was amplified among Black participants, especially, who obviously have a unique relationship with trust of law enforcement and believing that they'll even adhere to Good Samaritan laws if they show up on the scene, right? So there are a lot of ways that these two policies are really at odds with each other. And the last thing I just want to say is, you know, as discussed with the case of most of these people being friends and family, we also, you know, you've both mentioned that there's like this false dichotomy between people who use and people who sell drugs. And in a lot of the studies that we've done in Baltimore, when I was working with Dr. Susan Sherman's group out of Hopkins, we there were several cohorts where we spoke with people, and up to half were participating to some extent in the drug market for survival. 17% said it was their primary source of income. And so there isn't like this difference between people who use and people who sell. And I'll add, there's also a false dichotomy between police and people who sell drugs, because we have a lot of that in Baltimore too, is police participating actively in the drug trade.
Yeah, no, so I really appreciate you bringing that up, and because I think that's important for us to bear in mind. And I especially appreciate your attention to how real these moments are when people need to figure out what they're going to do when someone that they care about may be dying, and how criminalization can pose a barrier to any sort of effective response. And I mean, certainly we've seen this as well in some work that we've done with sex workers around the overdose crisis, around what can turn into a hesitancy to contact help because they'll be at risk of charges, and then, potentially child apprehension and all of the other things that can come from an entanglement with the criminal legal system. So many of the underpinning logics that operate around this are deeply carceral. They're focused on punishing people with this idea of punishment being a deterrent from, things entering the drug supply that might put people at risk. At least, that's one of the logics that's often brought up. If we crack down on people selling fentanyl or things with other adulterants, this will eliminate it from the supply. But I think we really are beginning to know that that's not the case. And Canna, specifically, I'm wondering if you could talk a little bit about the work that you've done, and this more broadly, as what it means as we crack down on supply, for what the supply can actually look like, and how we might understand the effectiveness of something like drug seizures, or increased efforts to actually disrupt what's happening.
Yeah, I think maybe I can speak to one of the studies we have recently done in Vancouver around like a drug seizures by police. And then I think there is another one done in the States, Indiana, about looking at similar stuff, but it's slightly different. So to start with our own local study in Vancouver, so we looked at the rates of people who use drugs being having their drugs confiscated by the police, even without arrest. That policing act is really creating health and safety risks for people who use drugs, because they have to, we found out that 70% of people who use drugs who had their drugs taken by the police, they have to immediately go back to the drug market and get new drugs, for sure. And then especially in the context of the ongoing toxic drug crisis right now, it's every time you go back to the drug market, especially you have to get drugs from unknown dealers, because you might be experiencing some withdrawal symptoms. So you have to get new drugs right away. That will really increase substantially your overdose risk. And then that's been happening. That's like right before the BC, the Canadian province of BC started to, their own version of the decriminalization policy in January this year. So this data was before that decrim framework started. So we are looking at the data in 2021. That was the result. So that was clearly the sort of like a police action on, there are some of the previous qualitative studies or interviewing police officers in BC were reporting that some police officers were taking drugs from people who use drugs as an overdose prevention measure, because they thought, these days drugs are so toxic. So when they found people, they may not arrest people for possession, but they may take drugs from people because they think if they're going to use the drugs, then they may overdose. So that is really contradict with what we have found, that it's actually really increasing their overdose risk because they have to get new drugs right away. And then we also, I think that many of you have seen this study published in American Journal of Public Health 2-3 months ago, that is looking at, that is a more ecological study. So that they're looking at police statistics around like drug seizures. And that doesn't, I don't think they looked at drug seizures without arrest, but looking at the police statistics around drug seizures and whether the places where drug seizures are happening were associated with like a spatio-temporal clustering of overdose in Indiana. And then they found that significant relationship. So that that is also an indication of that type of the supply reduction law enforcement activities might be really associated with overdose risk. So that that is really questioning about, you know, I think in the past, like when we talk about the drug policy, we say like we have 4-pillar policy, like supply reduction, demand reduction, harm reduction. But then like it's like in the context of the current toxic drug crisis, that like supply reduction is really might be really increasing the overdose risk. So that really, I mean, again, we even already know that supply reduction or law enforcement activities are always so like at odds or interfering with the harm reduction measures, but and that is really increasingly more problematic in these days.
Yeah, no, thank you, Kenna. And I think, I think you've all now kind of touched on different elements of criminalization that are in tension with a public health response, be it how, drug-induced homicide laws can undermine Good Samaritan laws and efforts to ensure that folks will respond, that they'll be there. And Kenna, I think you really captured very well the futility of thinking we can intervene in markets in this way. Generally, I mean, your fantastic work pointing to the impacts of drug seizures on risk, so important because it's something we've seen for years. And the great paper, I think Brad Ray at RTI led it in AJPH, that really touches on how drug seizures and law enforcement can drive overdose risk. And I think it's something we need to keep hammering home, and unfortunately have to keep doing work around because of the impetus to structure our laws only in a way that can punish, or at least primarily often in a way that can punish. Louise, I'm wondering if you could talk a little bit about the work that on the ground harm reduction folks are doing, and kind of collectively how these approaches are undermining our ability to respond to the overdose crisis, both directly, and I think you've captured really well how they're impacting people's decision-making in terms of how they're using drugs, who they're using drugs with, and whether they can contact 911. But I think these are situated within much broader efforts to find ways to more meaningfully intervene. And how is this impetus toward criminalization and penalizing people impacting our way to do that?
Well, I think number one, we just have a lack of imagination all the way around as people. Like, we need to get with like more than, we need to get a whole bunch of different folks that are really smart in a room and just go at it. As far as ideas, one of the things we came up with was going to, and Roxanne Saucier and I worked on this a little bit, and hopefully we'll pick it back up soon, was developing things for district attorneys to say, or to parents who come into their office or call them crying and say, my child is dead. You need to do something about this person, right? Of course, anybody with any compassion is going to say that the natural reaction, right, is we will lock that. I mean, that's what they do for a living. They lock people up. We will lock that person up. I believe that if they had some other language at the tip of their tongue to share, that might be better, right? We've already tried locking them up, and we've already heard that we can't lock our way out of this problem or arrest our way out of this problem. And these same people have said that. So why do they continue to do this? Well, we know why. Because they don't have anything better to say. They haven't thought, and they haven't been given the tools to adequately discuss this. As a person who's lost a child to overdose, I know the pain and horror, and that especially initially the anger that you have at everybody, and you want something done. And we have to have the language to give people so that they feel like they're addressing the problem, and that they feel like something is actually happening in this moment. And that is what we have not addressed. I mean, we really have not addressed that at all. So I think that's number one, is really thinking about, we got to give people tools. They don't have them naturally on their own, and they're not having meetings to sit down and think about, what could we say other than this? They're going with what they know, which is good old fashioned lock them up. That's what people want to hear. And so that's what they say. So that's sort of the first section of this. The second piece is, know know who you're talking to. So if you're talking to drug users, what can the drug users do? Well, that's why we developed Reframe the Blame. Get involved with Reframe the Blame. Understand what Reframe the Blame is. Let's build Reframe the Blame up to more than what it is now, right? Let's get some money into it, and let's make it a real program that can really address. And for those of you that don't know what it is, it's drug users signing something that says, look, I'm using drugs of my own free will. I'm doing this. I don't want to participate in your drug war. Please do not, please do not arrest anyone on my behalf if I'm to die. These are my friends, my family. I know these people. I got these drugs on my own. I wanted them. Whatever it needs to say. We have some language that we use that's not exactly that, but that's the idea. We're making cards now with people's faces on them. But with real money, we could infuse that project and really make it to be something. And no, it doesn't have legal, it doesn't have any legal meaning now, but when someone dies and it gets brought into a court of law, who knows what these things can do. I just know that it means something if I die and they hold that card up and say, you're really going to arrest somebody, when she's written right there in sort of an advance directive that she doesn't want you to. That seems like it would be a newspaper article at the very least. You know what I mean? So I think that's number two, is let's build that up. And three, let's talk to the parents of people who've lost like they've lost their children. They get together and they get angrier, and then they form really big groups of angry parents who've lost children, and now they're just destroying more lives of more broken folks who've been through so much trauma already, when what they need is some education and some love and some compassion and some real movement on reducing the drug overdose crisis. Because as we see the numbers just pile up, it doesn't look like anybody's doing anything. And the truth is, when it comes down to listening to people who use drugs, they're not doing enough, for sure. And so let's educate the people that have lost children, and let's form groups for them and get them information and access to care that they really need to cope with the loss of a child. That is, I don't know that you ever come out of that. I'm still working on coming out of that. Just like even being able to be present. Those are devastating things that so many people are experiencing now. I mean, it's overwhelming to even think about. I mean, we talk about numbers all the time, but I don't think people have any, when you're in it, when you're in the pool of people that are, I mean, I've lost my whole, we were looking at pictures of St. Louis DPA conference and the drug user union and people that were around. And I was looking at the people that were there. Everybody's dead. I mean, so many people are dead or have been damaged by the drug supply, are really sick, not able, coming out of like trying to deal with their own personal crises, such as myself. I mean, really, it has been a nightmare for people who use drugs and people who suffer with substance use disorder, or have, unique relationships with substances, whatever it is your situation. But I just want to, I know I talked a while, but those are the things that I really think would make a difference.
I mean, Louise, the great part about you talking is you can never talk too much. So I really appreciate that. And I mean, I share, and I mean, doing this work sometimes feels like you're constantly haunted by all the people you've lost, because it's unrelenting, especially right now. And I think you've really captured an important dynamic just to reinforce with folks is so much of how we're approaching this is it's blaming individual people for what's ultimately a structural failure.
Yeah.
Both in terms of the conditions of that folks who use drugs are in, to what the drug supply looks like, to I think as especially as Saba and Kenna have captured how an enforcement-based approach makes things worse. And I think we need center that. You know, I think one of the things we're all really aware of is we're also, this is all happening amidst a period of, drug policy experimentation in different places, given how rapidly things are changing. We have a setting like BC or like British Columbia, Canada, or like Oregon in the US that have decriminalized under some kind of model of decriminalization, while, in the case of BC, working to rapidly kind of pull that back in ways that are, I mean, to be blunt, pretty fucked. And we're now kind of navigating this rapidly transforming terrain of drug policy and intervention and evolving drug supply. And Kenna and Saba, I know like so much of the work that you've been done, it's been done in settings with this being done officially, or, in the case of Maryland or Baltimore, more kind of de facto decriminalization in different ways. And, I'm wondering if you could, what have these changes on the ground meant for folks who use drugs? So for example, decrim or, an emphasis on different approaches, and how might they actually point to some of the limitations of something like drug decriminalization as a response to what we're doing right now? I'm not sure who would want to jump into that first.
I can start. Thank you. Yeah, so I don't know. I think people are more aware of Oregon and BC maybe than of what is going on in Baltimore and a variety of other jurisdictions across the country. But in places where there haven't been successful legislative efforts to decriminalize all drugs, I'm not talking about cannabis or psychedelics right now, but really all drugs, and particularly those implicated in the current overdose crisis, in settings where there isn't a ballot initiative or it hasn't been feasible to get legislation passed, we have an increasing number of prosecutors who are just saying, like, prosecuting low-level drug crimes is not working. It's a revolving door, people coming in and out of jails. They're not charged for a long period. They're not kept in the carceral system for long periods of time, which is a good thing. But it's a drain on resources. And then obviously there has been increasing, I think some penetration of certain actors in the carceral system with messaging around public health, and substance use as a public health issue and racial justice issues. So you're actually seeing a lot of prosecutors around the country kind of take it upon themselves to join this wave of drug policy reform on the more progressive side in some way, right? And what the danger can be both of official legislative measures as well as these de facto measures is that in an environment where there's also, this media sensationalization and this fear and panic around the drug market, and just enduring structural racism, a lot of the arrests for something like drug possession can actually be offset. And you're seeing, so for example, in Philadelphia, after they decriminalized cannabis, they saw that that the disparity in arrests among drug sellers grew a lot, so that people of color were being either more targeted or there was no change in how they were being targeted with these drug sales, right? Arrests and charges for drug sales. And then basically everybody in the white community, their arrest went down to negligible levels. So, and in Baltimore, we also have seen similar things, that arrests for possession have gone down immensely in the Black community since the prosecutor stopped prosecuting, and that's great. But the disparity still, and this is just still for possession, the disparity in arrests, remains. So I think that broadly speaking, I'm starting to believe that decriminalization is necessary but not sufficient, maybe. And then I also have a concern that in these places where people are fighting tooth and nail to get any form of decrim through, there's a tendency to demonize, to double down on harmful narratives around sellers and to demonize selling because they, in efforts to differentiate their policy from one that would totally liberalize the market. So we've seen this in interviews with prosecutors around the country, where they continue to say to the media, to their constituents, like, we're still gonna, we're gonna be really harsh on those dealers, of course, but we're just saying we're gonna stop charging for possession because we're in a public health crisis. And I think that is, an effort to get something through right now, like to expedite whatever whatever can be done, but it may really be harmful in the long term as the public health and harm reduction community are now faced with, okay, how do we undo some of the narratives around sellers, people who are selling? But if we've actually contributed to some of that narrative, it gets really sticky.
Yeah, no, thank you. Ken, I'm wondering if you could chat a little bit about the BC context here in relation to how we might think about these changes for selling at drug markets.
Yeah. So I think first of all, I think we need to be really clear or realistic about what DCRIM can do. And the DCRIM cannot address the current a toxic drug crisis. They cannot really, they are not really addressing anything about the drug supply. And what they can do if it's done collectively is maybe more to reduce a stigma around drug use. But I do agree that the DCRIM policy can have sort of a double-edged sword in that they may create false distinction between users and then dealers. And that is actually happening in DC because when they are determining their own DCRIM policy, they have to come down to define what is the cutoff threshold amount of drugs people can possess for personal use. And it varies a lot of those individuals. And then they at the end, there's a lot of pressure from the police, and they came up with this really low cutoff amount, which was a 2.55 grams. And then that is not enough for many people who use drugs. And it's been a lot of advocacy from the community side and other public health advocates, but that finally they came down to that amount. So when it's on that paper or in the pilot policy paper, then that really determines whether you're a user or dealer almost, right? And then that's really a false distinction, and that may put some more vulnerable, more marginalized people who use drugs at higher risk of police violence and then all the criminal justice involvement. So that's really actually a really almost negative consequence, could be a negative consequence of this current BC's a DCRIM policy. And then just last month, they also introduced a new legislation, Bill 34, that actually they're going to newly ban the use of the drugs in the public places, most of the places in the public. And that also, and without introducing any measures for increasing supervised consumption sites. So that really means that really harming the most marginalized population of people who use drugs, who don't have any other places to go to use drugs, and then people may be unhoused. They may be at a higher risk of police interactions now. So that's unfortunate, really, that the BC's DCRIM policy has been watered down. It's actually now turning into maybe a more violent policy for some people who use drugs.
Yeah, no, Ken, I appreciate you.
Sorry,
Please.
I'm sorry, I totally.
No, please.
I just wanted to add on and maybe ask everyone this question because it's something I've been thinking about. But this issue that you brought up of thresholds, right? So in policy, that's really where the line is drawn between someone who uses and someone who sells, right? And in speaking with some of these prosecutors, some have just decided to not have thresholds anymore in making that decision. And they said, we don't want to use a 1 gram or a 2.5 gram cutoff. We want to say that someone maybe is using drugs at whatever quantity, and we would really need other evidence to actually prosecute them for selling. So it seemed like this kind of great idea of let's just do away with that arbitrary threshold. But then on the flip side, something I've learned in this research is anytime you offer more discretion it will allow people to then at very, very low thresholds charge certain people with selling and not others. And so I'm kind of curious what you all think of that. What is the right way to go with threshold? I mean, right way within this basically set of terrible options that we have.
I mean, I'll jump in to say we have terrible options. We have really terrible options right now, because all of this is wholly inadequate to addressing the harms that are produced, or doing so in a way that I don't think can avoid repeating the harms that you bring up. Like, if you don't have thresholds, and it means discretion, which ultimately means people of color and indigenous folks being disproportionately charged and targeted. If you have thresholds, especially like BC's, which, I mean, that's a really low threshold.
It's bad.
It's laughably low. Especially for folks who might be using multiple substances. Then you have something else that's wholly inadequate. And yet, I mean, really, it just points to the need to really pick apart the underlying logics of things being grounded in an approach that, you know, penalizes people, that has a wholly carceral solution to something that needs public health, or more even just market-based intervention. God, I feel like I'm going to die inside having just said market-based intervention, but that creates a space for a legal market for drugs that can displace what we have in a way that actually works.
Well,
please, Louise.
we do have tobacco and alcohol regulated, and it's not a terrible system, right? And they are the two most dangerous drugs that we know of. So for those that are like, oh, you're gonna, you know, there is possibility. I don't see it in our future, but I did want to say that anytime there's these you know, these numbers, once again, you have people that don't use drugs informing those numbers at all. So you have 2.5 grams, and well, 2.5 grams of what, you know, and there's a million reasons to not intervene in those ways. You know, if you buy fentanyl and you find out what you're able to use, and then you buy a large amount and then create a safe supply with it, safe supply might not be such a bad idea. But that's not even being discussed from what we hear from people at the CDC. So safe supply isn't even on the table. So if safe supply options aren't on the table, then I say we have to go even further, because anytime you have these amounts, you have the people that have good lawyers will say that they misjudged the amount and they'll get thrown out, and the people that have not the good, you know, it will be affected by economy, race, all of those things, and we'll continue to see the same problems. But if you have any cultural competency, it's better than none. I mean, I think our Good Samaritan law is so tricky that I don't understand it. I mean, you can have this many pills, you can have, and none of it makes any sense in the real world about what is a normal amount for a person to use. But I think that they have, you know, 2.5 grams of fentanyl as something horrible here. I mean, when that's not, you know, there's different weights. And I need to say polysubstance use is a much bigger thing than people are giving any, like, we are talking about these drugs as if people use them in isolation. And maybe we did years ago, because that's what the supply, I mean, I don't think when I was young, heroin was available, cocaine was, and so we used cocaine. You know, you use what's available, and do your best, I guess. But things are very different now, and so the availability of drugs, what people use, polysubstance use is huge now. You can't very well use all of these tranquilizers without using something to help you stay awake. And so we have drug sellers now selling all kinds of different drugs, and then we see contamination, which I think is what we see more often than we think. It doesn't take very much fentanyl for the strips to test positive. We know that. They're very sensitive, because I don't want to say something I'm not sure of, but I think they were urine sampling tests. So they're very, very sensitive. And so they pick up fentanyl very easily. And so it doesn't take much. Everything's white. And if you're messy like I am, then, you know, I think one of my friends said it was the messy drug dealer theory. You know, people just get this stuff contaminated if you don't change your gloves, if you don't change your, you know, all of those things make it difficult for all of this. And I think there's so many different issues across the board that when I talked about cultural competency around drug use and drug selling, I can't like emphasize that more for this conversation. We have people that don't understand drugs and the way people use them, making rules about the way people are punished for them. You know, I think we have mandatory minimums for certain amounts of drugs, you know, because you're definitely selling if you have that amount of drugs. You know, these kind of things, it's all ridiculous. I know people that have spent insane amounts of time in prison for and they were not serious drug sellers. They were drug users that were sharing with their friends or making a little bit of money on the side. So I just think that all of this reflects a poor understanding of how drug use works. And it doesn't work the same in every area. And I want to emphasize that too, because I think for a long time, I thought, geography may not make that big of a difference, but it does. Where you are, rural areas versus, you know, big cities and, you know, all of these different things, it all matters. It all matters the way the police engage with drug sellers and drug users. It all matters the way racism is, you know, executed and how it's built into its structural, you know, all of it is all different. And so there's not one answer that's going to fit for every state or every place. It's going to take a real investment in understanding what's happening. But what they could do right now is get methadone right. You know, the real simple things, which they won't do. We hope they're trying. But, you know, fuck trying, just do it. Get methadone right, get people in. They need more methadone, not less. Get it to them faster. And don't have these barriers. Don't throw them out for using. That's ridiculous. Why would you throw somebody out who says, I can't stop using drugs, and then throw them out for using drugs? That doesn't make any sense. You know, so there's some really simple answers. We're still investing in religious programs that don't really help people. We're still trying to use old antiquated systems of rehabilitation that are that fly in the face of any science or research. And we try to make it work somehow and try to make it all fit in. We need to get people into spaces with safe scientific programs that actually work, that are not all abstinence based. Not everybody wants to be completely sober, and that's okay. And I don't even know what that is.
I mean, thank you, Louise. I mean, that's definitely something we've seen, documented, heard in years and years and years of work. And I think you also perfectly captured what would really be kind of my final question to the group, and I put it to Saba and Kata, which is basically like, you know, where do we go from here? What changes do we need to how we structure drug markets, and especially drug selling, to more meaningfully intervene amidst the overdose crisis? And maybe go to Saba first, if you don't mind, because I have a tag-on question for Kata.
Sure. What are the answers? I mean, I think, as Louise said, there's several, you know, I completely agree with the cultural competence thing. Absolutely. Like, that's so well illustrated by the threshold thing, where you're just like, you guys, no one here has ever used drugs. These are the thresholds that you're making up. And so I think there needs to be more cultural competence, but I don't know how much certain people in power want to make these laws make sense or be humane or help people. I mean, I think something that we see in a lot of the research around criminalization and policing is that you know, we've talked about whack-a-mole with the drug market. There's also sort of whack-a-mole with drug policy, right? So every time there's like a more humane policy that can finally be brought through, there's this like insane backlash and 12 more policies that are hyper punitive. And there's these like insidious workarounds that are used to still criminalize people. And I actually at DPA, I attended a panel about this, and I believe the speaker was from Peru, so it was a very different setting, but he was saying that they have decrim for every substance separately, but as soon as you have more than one substance on you, no decrim applies anymore at all, like none of them individually. So, you know, which also speaks to what you said, Louise, about polysubstance use just not being considered or protected or written into any of these policies. But, you know, so I think that, I don't know that I'm getting to what the answer is, but I do think that there's I think that each of these policies that is promoting reduced criminalization and human rights for people who use and sell drugs matters, of course, but there's this like piecemeal way where they're going through, and we have, I'll put in the chat, I worked with some people on a paper around Good Samaritan laws being an example of this, of like getting one thing through, but in an environment of persistent structural racism where no upstream issues are being addressed, as you had mentioned earlier, Ryan, and where there's just like this many-headed monster. Or actually one analogy that I really liked was, I don't know if anyone played when they were young, the game Floor is Lava, where you have to kind of jump from like stone to stone in this, you know, in this environment of danger. And that sort of feels like what a lot of our more progressive policies are, is like we're offering these places for people to hop to for momentary safety, but in an environment of really, really persisting structural racism and and like enduring, you know, housing crises and lack of access to treatment or methadone or any kind of maintenance. And so I think I'm beginning to feel that like more sweeping approaches are needed. I know that then that gets us into the debate around incrementalism and like versus revolution. And I don't know if we have enough time left on the panel to fully delve into that, but maybe I'll just leave it there.
Yeah, I mean, we definitely don't have enough time left on the panel to delve into that. Though I definitely think that's something we should take up in the future. And I love the floor is lava analogy, especially right now where so many people are actively working to increase the amount of lava through really regressive backlashes against harm reduction. And Canada, tweak this question for you a little bit, because I think we have an unfortunate but really important example of that just happened in BC last week, where we saw the arrest of Eris Nix and Jeremy Callicum of the Drug User Liberation Front. And for those who might not be familiar, so Dolph had been effectively sourcing, purchasing drugs via the dark web, testing them, distributing them at protest events, and then also selling them effectively at cost to a small number of people who were effectively enrolled in what functioned as a bit of a small trial. And last week they were arrested. And I'm wondering what, Kenna, you might comment on what these arrests tell us about the entrenchment of carceral approaches to drug use, and what might we go from here as we try to figure out new ways of drug distribution for things that are safer when the supply is just so unbelievably toxic.
Yeah, it's really outrageous that the authority arrested those two individuals who were leading the DULF, the Drug User Liberation Front, and the community-based compassion plan. And I think we need to be clear that they are not like really selling drugs for profit, right? Like they're doing health intervention, they're doing providing a safe supply for people who need them. And so it doesn't really make sense to criminalize those people who are really saving lives of those people. And I think just thinking about like your previous question around where do we go from here, I think we really need to address the supply that is really driving this overdose death. And then none of the measures we have in in place in North America are not really directly like addressing the supply. And the safe supply or compassion clubs are the the only intervention that could address the supply. So we need to investigate that. And then it's really simple that if you go look at the history of the harm reduction, those like effective harm reduction health interventions are always coming from the community. And then the Compassion Club is also a community-based approach, so that we need to investigate how, and then they actually already have provided some preliminary data on how that Compassion Club at the Dolphin is operating, and then it's really showing the promising results. So that I really hope that any people working in public health like take it seriously and really investigate how this model can be. Well, first of all, we really want to investigate the benefits of it, and then if it's effective, then we really want to investigate how we can apply that model more broadly.
Yeah, no, thank you, Kenna. And, to reinforce a point, I really appreciate you bringing up that so many of the promising approaches and things that have worked over the years, let's bring this all the way back to syringe exchange, have come from the community, but they've also come from people breaking laws that are unjust. We don't have syringe exchange because we asked for it. Most places we don't have naloxone exchange because we went hand in hand with the government and said, please let us save the lives of the people in our community. We don't have supervised consumption sites because people, waited around for public health or medicine or other people to act. They just did what needed to be done to keep people alive. And I think that's certainly a spirit that we've been carrying across the webinars that we've been doing as part of the series of direct action has been instrumental in terms of advancing so many of the things that we have to keep people alive, while also really impacting their scalability at the population level, which is, I think, really one of the things that we're now faced with in terms of how can we transform a drug market? How can we do so in a way that can reach people, that can disrupt the toxic supply and so forth? So we're going to jump to questions in the Q&A now. But before we do, I just want to thank you so much for just such a thoughtful conversation and brilliant comments on how we can think through things. So, hats off to all of you in case we end up rushed at the end. There's a great question here by DJ Larkin, who's the Executive Director of the Canadian Drug Policy Coalition. So how would you suggest that defense counsel representing people charged with trafficking, possession for the purpose of trafficking, culpable homicide for selling, sharing drugs, incorporate an analysis that would decrease the narrative that someone is either a victim, arguing that they're selling because, it's an indicator of victimhood or, structural violence that requires carceral treatment, or a villain, they're bad, they're predatory. So a lot of case law draws that distinction that, someone's either a victim or a villain. And lawyers then often fall back on kind of those rehearsed tropes in terms of what they do. So what other avenues might we take, or what other pathways might we choose to follow that would really disrupt those as being the two ways that we go about this?
I could say something, it's a little controversial and I don't necessarily agree with it, but something that we've seen, so in Baltimore where they stopped charging for possession altogether, there was a lot of concern around, I think, there was a lot of concern around like, well, what will we do with the drug court infrastructure now, right? And so, and not something I was particularly bothered about, but this was a concern in the jurisdiction. And it was sort of interesting because what I've started to see, and again, I don't know, I haven't seen exactly how these programs operate, and they could be dangerous, and I think we really need to like look closely at them. But what we started to see in some places that are no longer prosecuting possession at all is using some of that diversion infrastructure for people who sell drugs or people who are committing other crimes that are deemed adjacent to their substance use. So for example, not possession, but if somebody is involved in like a domestic assault situation and it's sort of deemed that this was related in some way to alcohol or drugs, using this like in the court infrastructure that was there and some of the arguments and the procedures that would have previously been used for somebody with a simple possession charge to say this person still shouldn't be charged and serve time. This is the series of things that led them to this moment. Is there a way to divert them out of the system? And so I say that with the caveat that like I don't believe in any kind of coercion or coerced treatment, certainly, but it'll be interesting to see how the use of that infrastructure for other crimes and other charges plays out.
Great, thank you, Saba. You know, I would jump in to say that, I mean, we probably just need a much more deliberate and thoughtful challenging of this idea that anybody's a villain in the context of the drug supply and drug selling and how markets operate, in part because it assumes that you have random nefarious actors, you know, popping up who are preying on people, selling drugs that are intended to kill them or anything else. And that's just not how drug markets function, as we've heard from everybody. So all of this is basically built on this horrible premise that is so utterly absurd if you understand at all how a drug market functions, who has control over the supply, and what that really means at the ground level, that ultimately people end up being picked up for trafficking, for drug-induced homicide, and for all of these other things. Like, it's just, I mean, you may as well imagine, like, it's basically imagination land, for God's sakes. It's worse white supremacist fears about who deals drugs, who controls drug markets, and who sells them. And, you know, rejecting that logic and really picking that apart is probably part of something that we need to do, because then you can situate how drug markets operate in a much more materialist perspective, as they just operate as a market in the way that anything else that there's a market for operates. And within that, there's then different things that you can do to promote safety. And we just don't do we don't do well in doing that because they're criminalized. So yeah, just to reinforce that point. And Louise, I felt like you were going to jump in, so I just want to give
Well, I was just going to say, we don't do well with that with anywhere in the US. I mean, in our society, you're either good or bad. You're either right or wrong. You know, we want these very black and white, you know, we have heroes, we have villains. You know, in other cultures, they have stories where people, you know, your hero can also be a villain. And people do things for all sorts of reasons that are way more complex than they're just evil. You know, and I think that that's sort of across the board we do that. And that's just a cultural flaw. And a misunderstanding of the way the world works, and people needing very simplified, you know, people want quick answers to complex problems, and they don't want to spend you know, and we don't spend enough time really, we spend so much time fighting, and on the other side of the line, you know, sort of just preventing all of this terrible, you know, pouring water out the boat, you know, with a cup. We don't spend enough time with our best and our brightest developing something that looks like it could work. Because I believe anything you start doing where you build connection for people is where it begins. You know, all we do in the US is we you know, from the very time you're learned that you use drugs when you're young, you are separated from your friends. Oh, you can't hang around with Billy anymore. He's the problem. And then you're pulled out of school. And then you're pulled out of, you know, and then you can't work. And then you can't do this. And then you can't do that. And finally, we take your freedom. And when we take your freedom, we have demoralized you, and you have nothing left. You're hopeless. You know, when you can't do anything. I mean, and I have been in that space, and it is devastating. And that's why it's so important that we bring people who use drugs to places like this, help them do the cultural analysis that's necessary for them to see that they're not individually responsible for the drug war. And we allow them in this space to make money and to be partners in something that they do have a lot of experience in. once we we do the education and we get all of this right, it changes your life. And it may not make your life perfect. Certainly hasn't made my life perfect, but it's changed my life from a place where I was hopeless to a place where I feel like I have a space and I have a place, and that people will listen to me and they do see me as someone who contributes to society instead of takes away. And I think if that miracle is available to everyone, then we need to make it available to everyone. It can't just be the people with the highest access to university education and to these things. We have to allow this space to take everyone. And that's why we give computers to people in our Health Hub program. So it's not just people that have the computer or the car. We want to make sure that everyone has access to the different tools that we're providing folks. So that's just, on my mind as far as once again, I don't know if I even answered the question.
No, that's great. And, I'm noting time, and Louise, there's two separate questions asking if you could talk a little bit more about Reframe the Blame. And I posted the link, and I'm just, for those joining, could you?
Yeah, Reframe the Blame is simple. It's just, it is a concept we made at the National Survivors Union. It was, sort of this idea that we are using drugs it's our own decision to use drugs, and we don't want anybody arrested for that. We have cards that we'll make you with your picture on them, and we will hold, the piece of paper that you sign, or you can develop your own version of it. We would really like to build Reframe the Blame Part 2 and really do the research and figure out how to make it the most effective program that it can be. But I believe Ryan put a link to what's available, and that was just the start. But these toolkits could hold, the things we tell the DA, the things we can go do in our community, holding family groups, talking to families. The cool thing about Reframe the Blame is you can go to your family and you can say, look, I have this card I signed. It's like an advance directive. Please, if something happens to me, it's a conversation starter at the very least, tool of engagement. I signed this card. Now it really is, it doesn't mean I'm using, it doesn't mean you need to freak out, but I do want you to know what it means. And I do want you to, and I do want you to use this if something was to ever happen to me. Some people can't have that conversation with their family. Some people can, and they should, or their friend. And then that way, if something was ever to happen, which unfortunately in this age, things do happen, then we have that card. And at the very least, we can go to the media. We can fight with it. We can use it as a tool. I'm sure there's plenty of people on this call that would be very interested to know you had a card and had overdosed and these charges were taken out on somebody, and using that as a way to change the way we feel. And because it changes the way parents like to think that their children don't, well, Louise doesn't sell drugs. Well, that's just not the way drug using works. So if I use drugs, these things happen. And so having these conversations so that they know that it's not just, big mean villain over here who convinced me to use drugs. That's the era I'm from. We get the kindergartners. We got to do better. And Reframe the Blame says to the world that you're ruining more than one life with a drug-induced homicide law. Basically, Reframe the Blame, this person's already died. Devastating. Let's grieve that person. Let's make that life worth something. Let's make some real change. And let's not just destroy someone else's life who really had a chance to have something, So yes, please, it's something that we could really use help with. We could use funding around, we could use research around. So all of those things are available, and everyone knows how to get in touch with us. So, just be in touch if it's something you want to, if you want to utilize or figure out how to create your own. We're not married to having to be a certain way. We just want people to use it.
Great. Thank you, Louise. Thanks so much. It's such important work. And I really appreciate that it's actionable and helpful for people and points to the types of things that we need to be supporting communities and doing. We're basically at time, so I'd like to thank everyone so much for joining us, and thank Canna, Louise, and Saba for joining us today for a really wonderful panel. Happy Halloween, everybody. I hope everyone has a great day. If anyone figures out and puts together a map of the houses that are giving out free drugs, please circulate it so we know where to go. 'Cause I'm not convinced that's real. But if someone figures out different, help us out. And just to be clear, for disclaimer purposes, that's very not real. But everyone, thank you so much for taking some time in your day to join us. And the recording will be sent out to folks, and you can access it and past ones to our YouTube channel. And we'll be posting details soon for the next event, which will happen next month. Thanks so much, everybody.
Thank you so much.
Thank you.